Vitamin B6 is intricately involved in hundreds of metabolic processes, so it's not surprising that it interacts with a broad range of medications, over 50 by conservative estimates. What is surprising, however, is how rarely these interactions are acknowledged or managed in clinical settings. Many commonly used drugs either deplete B6 levels or impair its activation into its usable form, pyridoxal 5' phosphate, PLP. Yet, despite the critical roles B6 plays in neurological health, hormonal balance, immune function, and amino acid metabolism, routine monitoring of B6 status is rarely performed when these medications are prescribed. This oversight can quietly compound side effects, worsen long-term outcomes, and mask deficiency symptoms that mimic other conditions. Among the most well-documented interactions is with oral contraceptives. Birth control pills have long been known to deplete B6, most likely by increasing its clearance or interfering with its conversion to PLP. Women on the pill often report mood changes, fatigue, and even signs of neuropathy, symptoms that overlap significantly with mild to moderate B6 deficiency. While these symptoms are often attributed to hormonal shifts or psychological causes, they may actually stem from a slowly developing micronutrient imbalance. Yet few gynecologists or general practitioners routinely recommend B6 supplementation or testing for women on long-term hormonal contraception. Another well-established interaction is with isoniazid, a frontline antibiotic used to treat tuberculosis. Isoniazid binds to B6 and forms an inactive complex that accelerates excretion, often leading to deficiency and, in many cases, drug-induced peripheral neuropathy. Recognizing this, some treatment protocols wisely include preventive B6 supplementation, but this is not universally applied or emphasized. Similarly, hydralazine, a drug used to treat high blood pressure, and penicillamine, used in conditions like rheumatoid arthritis and Wilson's disease, can also interfere with B6 function and contribute to neurological symptoms. These are not rare medications, and yet B6-related complications are often not part of the diagnostic algorithm when side effects emerge. Even alcohol, widely used and chronically consumed, disrupts B6 metabolism on multiple levels. It interferes with intestinal absorption, impairs hepatic conversion to PLP, and increases urinary excretion. This is particularly concerning given that individuals with high alcohol intake often already suffer from poor diet quality, liver dysfunction, and increased oxidative stress, all of which heighten the need for B6. Alcoholics and heavy drinkers frequently present with signs of neuropathy, cognitive decline, irritability, and immune dysfunction, yet nutritional repletion strategies tend to focus more heavily on thiamine, leaving B6 to the side. Other common drug classes that impair B6 include antiepileptics such as phenytoin and carbamazepine, which compete with B6 in metabolic pathways, and theophylline, an asthma medication that may lower PLP levels. Even medications that affect the gut microbiome or cause gastrointestinal irritation, like metformin, proton pump inhibitors, or antibiotics, can reduce absorption of B6 indirectly, especially when combined with dietary insufficiency. The deeper issue here is that the symptoms of B6 depletion, fatigue, poor concentration, irritability, tingling, low immune resilience, are nonspecific and easily misattributed to the underlying condition being treated or to aging, stress, or mental health issues. Because B6 is rarely tested, and because its deficiency mimics so many common complaints, a downward spiral can occur. The patient starts a medication, develops subtle side effects. Those effects are treated with more medications, and the original micronutrient imbalance remains unrecognized and uncorrected. Furthermore, even when B6 testing is performed, it has limitations. Standard blood tests measure total serum B6 or PLP, but levels in the blood may not reflect tissue saturation or functional activity. For example, someone may have adequate circulating B6 but poor cellular uptake or enzymatic activation, especially if they have genetic polymorphisms or liver dysfunction. This creates diagnostic ambiguity, and again, the default is often to ignore B6 rather than address it proactively. Ultimately, the interaction between medications and B6 is a clear example of how the pharmaceutical and nutritional domains remain dangerously siloed. A deeper integration of the two, where medication side effects are evaluated not just biochemically but nutritionally, could prevent much of the collateral damage caused by long-term drug therapy. B6 supplementation is inexpensive, low risk at moderate doses, and well tolerated. There is little downside to protecting B6 status, when medications known to interfere with it are prescribed. In summary, the relationship between vitamin B6 and pharmaceuticals is complex but clinically significant. Dozens of medications interfere with its absorption, activation, or retention, leading to deficiency symptoms that often go undetected. By failing to assess or supplement B6 alongside these drugs, we allow subtle but important health declines to accumulate. Correcting this oversight could lead to better medication tolerance, fewer neurological side effects, and overall improved patient outcomes through nothing more than a few milligrams of an overlooked vitamin.